Now let's highlight some of the pharmaceutical drugs that we have in our arsenal to fight against type 2 diabetes. And in the first part of this picture, you're seeing the pathophysiology behind type 2. You're seeing the impaired insulin secretion, excessive glucagon secretion from the pancreas, increased hepatic release of glucose, that's gluconeogenesis, carbohydrate absorption, and we're seeing in the cells of the body that are insulin dependent a decrease in insulin responsiveness. So we're seeing insulin resistance. Now the bottom picture, part B, you're seeing how the drugs that I've highlighted here are going to affect their target tissues. First, I'd like to talk about the sulfonylureas, and the most best example of that is glucotrol. The thing about these types of drugs is that you have to have some sort of B cell activity. And how the sulfonylureas work is, if you go back to the picture from your book, you'll see that the sulfonylureas are going to augment the trapping of potassium. They're going to stimulate that potassium channel. And what happens is they're going to get more potassium trapped in the cell, and then the opening of the calcium voltage-gated channels, and the release of insulin. That's what we mean by insulin secretagogues. These are drugs that are going to promote the secretion of insulin. Now what about the next classification of drugs, the biguanides? Well, they're going to target the liver directly, and they're going to inhibit the gluconeogenesis aspect of the liver. And the best example of the biguanides is the metformin or glucophage. The two of them have the same anti-gluconeogenesis effect. Of course, there are other types of drugs I want to tell you that they use usually, many of these together, because they're not going to try and find out exactly in the type 2 diabetic where their disconnect is for proper insulin release and response. They're just going to hit them hard with many of these all at once. So in other words, the alpha-glucosidase inhibitors, alpha-glucosidase is an enzyme on the brush border. It's an enzyme associated with the apical side of your small intestinal cells. Basically, inhibitors of the enzyme are going to reduce the ability of your body to digest carbohydrates and then absorb the glucose monomers. So this is targeting your ability to absorb more. It makes sense. Dipeptidyl peptidase 4 is another drug, and it's going to target the release of more of the hormone GIP. GIP has two names for that acronym. It's either called gastric inhibitory peptide or most recently glucose-dependent insulinotropic peptide. This hormone targets the pancreas and stimulates the beta cells to release insulin. Now the last drug, TZD. Look, I've got a 5-vowel limit to the words that I'm going to try and pronunciate, so I'm not even going to try this drug. They are going to target skeletal muscle or adipose tissue. They're going to try to upregulate the insulin receptors so that the insulin that is released is bound to and responded to appropriately. Again, these drugs are our go-to for treating type 2 diabetes. Now that's not to say that the type 2 diabetic won't need any injectable insulin. The type 1 diabetic, of course, is going to need injectable insulin, but the type 2 could also be getting some as part of their pharmaceutical arsenal. Now we basically separate the types of insulin into, are they rapid onset, short acting? I've grouped two groups together with that. Are they intermediate, meaning they take longer to come on board and last longer? Or are they longer acting? They go about 24 hours, say. Sometimes physicians will prescribe insulin injectables and pair them. They might take intermediate acting, the neutral protamine hagedorn, the NPH type, and pair it with a rapid short acting. You know what they're trying to do? Look critically at this picture. It should remind you of another picture I've shown you already. What are they trying to mimic or mirror? If you're not seeing this, then I guess I have to point it out. They're trying to mimic the biphasic release of insulin, our own natural insulin. There is an acute release phase, remember, within so many minutes, and then there's a second release phase, about 10 minutes after the first phase. So that's basically what they're trying to reestablish inside the body, that biphasic release. Now it's time for us to go on and talk about the complications of uncontrolled diabetes mellitus. Why do we give a rat's whisker about educating our patients, whether it be type 1 or type 2 or gestational or any other types? Why do we care? The simple take-home message is this. With a diabetic who is not controlling their blood glucose levels, well, let's see, there are 3 polys and 3 pathies, as they say in the clinical setting. The 3 polys are polyuria, polyphagia, polydipsia. Polyuria is causing excess urination. Why? If you have more filtered load of glucose in Bowman's capsule because you have more plasma glucose, water is going to follow because you are not going to be able to reclaim, reabsorb all that filtered glucose because you're going to reach transport maximum, Tmax. Polyphagia, that means the person's always eating. Now, why would they always be hungry? Well, their body is sending out the hormone signals to tell regulatory signals that they are starving and they need more carbs. Polydipsia. Now, I think of a ladle, and I think of a ladle dipping into the water. Polydipsia is increased thirst and drinking. Polydipsia occurs because with uncontrolled diabetes mellitus, of course, we recognize the problem as volume contraction resulting in hyperosmolality of the blood. And this is the #1 stimulus for ADH to be released. And when ADH is released, it is also stimulating those thirst centers. That's why you get polydipsia. Now, what are the 3 pathies that we can expect? Neuropathy, which is nervous cell damage and death, and I'll talk about that in a little bit. Retinopathy, where, again, we're getting detachment of the retina, loss of photoreceptors, and the person's losing their sight. Nephropathy is well, it's not cool if you have it, but retinopathy with the diabetes first leads to increased GFR with loss of plasma proteins. They call it microalbuminuria, which means it's coming out in the urine. But with more and more damage of the filtration membrane and the glomerulus, it ultimately leads to a decrease in GFR. And I have a video for you to watch on that. If we want to continue on and talk about the other types of complications, again, these 3 polys and 3 pathies are kind of the go-to, but they're not the only 6 issues we should think about. In type 1 diabetes, we should recognize that our patient is most likely to have a problem with ketoacidosis. Lipid metabolism occurs through beta oxidation. The acetyl-CoA that is formed feeds into the Krebs cycle. Well, if you don't have adequate carbohydrates, you don't have enough oxaloacetate, which is the entrance point for Krebs cycle. That oxaloacetate will be reconverted back into glucose, in which case your acetyl-CoA cannot shunt into the Krebs cycle. Instead, it's going to engage in other metabolic processes. As a result, it will generate ketone body formation. Now, the 3 ketone bodies are beta-hydroxybutyrate, acetoacetic acid, and acetone. Now, of those 3, 2 of them are also ketoacids, which means they have to be eliminated by the kidney. They are beta-hydroxybutyrate and acetoacetic acid. The acetone is not a ketoacid because it's volatile. It can go from a gas being dissolved in blood to a gas out of our body and out into the air. So acetone is just a ketone body, not a ketoacid. Anyway, when we wake up in the morning and we have our morning breath, the reason we have our morning breath is because we've been in a mild state of ketosis. During the night, we've had 8 hours of sleeping, usually. And we've been in the post-absorptive phase, which means our bodies have been using fat as a fuel source. So when we wake up and we have that smelly breath, it's really a reflection of us burning fat as we've been sleeping. The uncontrolled diabetic can also have severe nausea leading to vomiting. The metabolic acidosis that results from their ketoacidosis will lead to CNS depression. That means they're sleeping all the time and not coherent. That can lead to infections. You know, sweet sugary blood, think about this. It most certainly is going to promote bacterial and fungal infections. And we can see in women more yeast infections in the vagina. We can see yeast infections on penises of men. We can see more thrush, the yeast growing on the tongue, you name it. The infections go up. We can see sexual dysfunction, erectile dysfunction. We can see, of course, excessive weight loss because they're using all the fat stores. We also see poor wound healing. I'm going to tell you about macrovascular disease and microvascular disease. And basically what happens is with poor blood flow, the tissue becomes ischemic. The tissues will then become hypoxic, anoxic, and die. Some of the tissues that die will be nervous tissue. and as tissues start dying, wounds will start developing. And I'll tell you why. They won't heal well because you're not getting blood to that wound, because blood vessels are not distributing the blood correctly because of the vascular changes. Anyway, we can have the patient have hypertension as a result of their uncontrolled diabetes. We can have them have elevated heart rate, and we can also see in them Kussmaul respiration, which is hyperventilation, in an effort to get rid of the CO2. Now, some other complications, as if that wasn't enough, that a diabetic might experience actually includes hypoglycemic complications. A patient who has diabetes can have bouts of hypoglycemia because they inadvertently injected too much of their insulin. This could happen, let's say, if they weren't mindful of their stress levels or how much they ate compared to how much insulin they've injected. It can happen. If they injected their insulin prior to exercise and then eat, well, exercise promotes entry of glucose into cells of the body. It potentiates the effects of insulin. So basically, it's almost like if the patient is exercising excessively, they're getting a double dose of their insulin. If they were under a lot of stress, and again, those counter-regulatory hormones like cortisol lead to increased blood glucose levels, maybe when they were under a lot of stress, they were increasing their amounts of insulin. Well, when all of a sudden their stress levels go down, their insulin levels are still high, I'm fairly certain you can recognize that this would lead to hypoglycemia. Alcohol consumption. Alcohol is going to decrease gluconeogenesis. So if you have decreased release of glucose by the liver, but you've injected your insulin and you're drinking your alcohol, now this is going to lead to hypoglycemia. Now other complications, like I said, are the counter-regulatory mechanisms. The Simoji effect is basically where hypoglycemia leads to hyperglycemia. So let's say the patient has taken their insulin regularly and during the night when they're sleeping. Their blood glucose levels drop more, still within slightly normal range, but a little bit more than they anticipated. When they wake up in the morning before they've even eaten a meal, they take their blood glucose levels with their glucometer and they come out higher than normal. What this is reflecting is the counter-regulatory hormones coming out full force and trying to mobilize glucose stores. So the patient will wake up aberrantly in the morning with hyperglycemia even though they went to bed fine and took their insulin fine. This is the Simoji effect. Now the dawn phenomenon is basically when the patient wakes up with higher than normal blood glucose levels, but they didn't inject insulin the night before. They didn't cause this drop in blood glucose levels because of their injectable insulin. When this dawn phenomenon happens on its own, without the patient saying they injected insulin the night before, this usually happens when growth hormone levels are highest. Growth hormone levels are highest shortly just before we wake up, so somewhere between 5 and 9 a.m. Now the thing is, when you release growth hormone, what does it promote? It's like cortisol. It tells the cells of the body not to use glucose as an energy fuel source, and so it has a diabetogenic effect. So when the dawn phenomenon happens without the patient reporting injection of insulin, this is usually attributed to the growth hormone. All right, I'm not going to spend too much time on this slide, but one of the big complications for uncontrolled diabetes mellitus is nephropathy. Basically what happens, if you watch the video that I'm showing you a picture of here on YouTube, and I uploaded it to your Blackboard space, watch it. It's all of maybe a couple minutes. What you learn is that there is a change in the blood flow to the capillaries that serve nervous tissue. And I'll talk about the macrovascular changes and microvascular changes in a little bit. But suffice it to say that there are changes in the vasculature. What happens is you're going to get plaque buildup, you're going to get rupturing of the vessels, but you're also going to get thickening of the blood vessels and reduced blood flow. And that's what you see in the nephropathy picture, but now I'm going to talk about neuropathy. Downstream tissue is not going to be happy with that, not getting adequate blood. So this means in the case of neuropathy that the neurons are dying. It can lead to initially loss of myelin, in which case a patient will complain of paresthesias, which is abnormal sensations like tingling sensations or pricking or feeling of being burnt, literally burnt. This is primarily going to affect the lower extremity first, but it can spread. When it affects the somatic sensory system, we're going to see the presentation mostly in the feet and hands of the patient. So that's what we mean by stocking glove presentation, because that's where you would wear stockings on your feet and your gloves on your hands. So the patient will have an abnormal response to any pain, vibration, or any temperature stimuli. There are also autonomic effects to the neuropathy, and the autonomic effects are going to include erectile dysfunction, which I've already addressed, but you can find a table of all these autonomic disruptions in your book. Again, erectile dysfunction. They can have problems releasing their bladder, etc. And again, it's initially from reduced blood flow. All right, now I'm talking about nephropathy. The reason why we're going to see the microvascular damage and macrovascular damage in the next few slides is because of we're going to see advanced glycosylation or glycation end products, or AGE. That's what that stands for on the slide, advanced glycation end products. Basically, this comes down to those proteins like albumin and hemoglobin getting riddled with glucose molecules attaching to them, and these molecules are going to behave aberrantly and lead to changes in blood vessel dilation, which will, of course, change blood flow to the downstream tissue. Now, what about nephropathy? Again, I've uploaded videos on it. It's perfect. It tells you about the mesangial cells responding to the blood glucose levels. It tells you how GFR initially goes up, but then GFR goes down. It also tells you how we get vasodilation of the afferent arteriole thanks to the disruption of the microvascular. Increased dilation of the afferent arteriole means that we have increased hydrostatic pressure of the glomerulus, and that means more filtration. That means we will lose albumin in the urine. This is called microalbuminuria. Again, the changes in the vasculature and the microcirculation are attributed mostly to the accumulation of glycation, the glycosylated products of these proteins in the plasma. So in the patient with nephropathy, we're going to see that increased GFR. With the increased GFR, we're going to lose our capillary colloid osmotic pressure because we're losing our albumin into the urine. Systemically, we can see a patient present with edema because they have less pulling power of albumin to pull fluid from the interstitial space back into the bloodstream. We could see edema, not always, but we could. We will see with advanced nephropathy that there will be reduced renal blood flow, and if we have reduced renal blood flow, that means the glomerular hydrostatic pressure will decrease, and that means now, towards the end stage, we're not getting adequate filtering of the blood plasma. And this can lead to the RAA mechanism, where the decreased blood pressure leads to decreased filtration, which leads to more autoregulation by the nephron. And I'll remind you, part of the autoregulation is the stimulus of the RAA pathway, where more aldosterone will be released, and that stimulates the late distal convoluted tubule cells, the principal cells, to reabsorb more salt and water. With more salt and water reabsorption, we're going to get more hyperosmotic expansion, and that's going to lead to hypertension. With retinopathies, again, we're talking about those glycosylated proteins, and it's going to affect the microcirculation. And result is, with uncontrolled diabetes mellitus, how does the microcirculation get affected? Really easily. With the sugar disruption, it leads to lipid disruption. We see the cells mobilizing fat sources. That means more fat in the blood plasma. That's called hyperlipidemia. And with hyperlipidemia, we're going to see more foam cells. And I'll remind you, that means macrophages internalizing more LDLs. That means more fatty acid streaks, and that means we're going to have more rupturing of the plaques and platelet aggregation. And also in these patients, we're going to have failure of fibrinolysis. We're going to see blood clots. It's a whole progression of stages, isn't it? We have to have this before we get this. Constellation of issues. Well, retinopathy is just one of those stages of the progression. We're going to get the microvascular issue all over again. We're going to get the death of the retina, and we're going to get detachment of the retina. It's basically what we're talking about. Now, the macrovascular complications, when I speak of macrovascular, I speak of large blood vessels, largish, I should say. The vessels serving the heart, the vessels serving the brain, and what happens with macrovascular complications is we get the hyperlipidemia, which leads to the foam cells, the plaque formation, the fatty streaks. and then the plaque formation, and the plaque rupturing and the activation of the platelets. And then that means the vessel is clogged, right? That can lead to a heart attack or that can lead to a stroke. So when we speak of the brain and heart blood vessels, we're speaking of macrovascular complications. But we also can be talking about peripheral arterial disease. And that basically is going to affect the lower extremities. And I show you a video of PAD and how it leads to neuropathy and can lead to amputation or heart attack or stroke. Our last slide is discussing diabetic foot ulcers and infections. And with this slide, I really want you to know that it goes with neuropathy. The point is this: if you have nervous cell damage and you have type 1 or type 2, and your person is not really monitoring your blood glucose levels, with time, the elevated blood glucose levels are going to destroy the nervous tissues of your body. So let's start with the feet and move upwards through the legs. So here you are. You're still mobile. You've got type 2 diabetes, let's say, and you're wearing brand new shoes. Or let's say you're a type 1 diabetic and you're a growing child and your shoes are getting progressively small. Well, the point is that with these new shoes or old shoes and you're growing, you're going to have brand new pressure points. Or, hey, maybe you have a small pebble in your shoe and you can't readjust your weight to avoid it. If you are not detecting the sensation of rubbing points from poorly fitted shoes or a rock in your shoe, you're going to develop a blister. And a blister can develop into a life-threatening wound if you have uncontrolled diabetes mellitus. And the reason is that with the damage to the tissue, it's going to lead to the hypoxia of the tissue. It's going to be positive feedback. That means we're going to see damage to the vasculature, the microvascular, which is going to exacerbate the whole blood flow to that injured part of the lower limb, usually as I'm showing you here. Then the ulcer is going to develop. The patient is totally unaware of these pressure points. So it's highly recommended with patients with DM every night when they take their shoes and socks off, they should examine their feet with a mirror. So in particular with type 1 diabetes, children who are undergoing a growth spurt are at a pretty big risk for developing these ulcers from not controlling their DM. A person with excessive growth hormone having a diabetogenic effect, it can lead to the neuropathy, it can lead to the ulcers, it can lead to the loss of sensation because of the ulcers and neuropathy. And the next thing we know, we've got an infection in that ulcer and they're going to get amputated from that lower limb. I showed you a picture of that on the previous slide. And I'd just like to finish up with, we can actually do a pressure point test, a monofilament test on patients' feet that we suspect have diabetes mellitus. Basically, we take this metal, the steel filament, and you push it up against the patient's foot, and you say 1 and 2. And for one of those numbers, you're actually pushing the filament up against the patient's foot. But the idea is you randomize when you actually touch them to which number you're saying. And even if the patient gets one of them, just one of them wrong, it's suggestive of neuropathy. That's how serious it is. So we do this monofilament test, and again, to remind you, that with sweetened blood, because of the increased blood glucose levels, once we get a wound started, it can be very easily taken over by bacteria or fungus because they've got nice nutrients to keep them going. It's in our patients with DM. We see the thrush infections or maybe athlete's foot. You should be mindful of dental caries. That means cavities in the mouth. The athlete's foot, like I've already told you. Urinary tract infections. All right. That's enough. I hope you enjoyed that as much as I did. I really like this chapter, and I hope you can tell that. Until next week when we talk about sleep disorders.